Okay, so we're going to move to our keynote address, and Dr. Marwan will come to introduce our keynote speaker. Thank you, everybody.
Awesome. Thank you. Good job. Thanks. We stole a couple of minutes. That's okay. Good morning, everyone. It is my honor to introduce our keynote speaker for the 7th Annual Houston Shock Symposium. Dr. Marv Konstam. He's not only a pioneer in the field of advanced heart failure, that I'll highlight some of his achievements shortly, but he's also my mentor from 15 years ago when I was at Tufts. I learned a lot from Dr. Konstam. Where is Dr. Konstam? I saw him. Oh, there you go. He's a professor of medicine and radiology at Tufts University School of Medicine. He's the recipient of the Distinguished Faculty Award there, a Chief Physician Executive of the CardioVascular Center of Tufts Medical Center. He is board certified in advanced heart failure and transplant cardiology, cardiovascular disease, internal medicine, and radiology. It's kind of rare. Dr. Konstam is an internationally known expert with over 350 published articles. Actually, a few of the presentations yesterday and today were citing his work, mostly on the topics of ventricular remodeling, heart failure, therapeutics, and diagnostics, and quality of care. He has served as senior advisor in the cardiovascular disease of NHLBI, multiple advisory panels for the FDA, and an active member of the cardiovascular and renal advisory panel for the Center for Advanced for Drug Evaluation and Research. He served multiple hats in addition to Tufts, including the past president of the Heart Failure Society of America, the president of the Association of Professors of Cardiologists, chair of Leadership Council of the Academic Cardiology Section of the American College of Cardiology, and member of its Health Affairs Committee. He is the founder and chief scientific officer of the Cardiovascular Clinical Sciences, a CV-focused contract research organization that has served as the chief medical officer of a startup CV biotechnology firm. He was awarded the Lifetime Achievement Award by the HFSA and the Paul Dudley White Award by the Mass American Heart Association. And it is my distinct pleasure to invite you to the stage to talk to us today at the Shock Symposium.
First, isn't that a great picture of me? You know, thanks so much, Marwan. But you used up half of my time for my talk. But I'll forgive you for that. Thank you so much for inviting me. It's just a delight to be here and an honor to be able to speak with all of you at this great conference. Congratulations for this conference that you've put together so well. Okay, let's see. So this is the title of my talk. I'm going to talk about decongestion and diuretic treatment. After 240 years, how far have we come? Sort of a mundane topic, but everybody in this room uses diuretics all the time. It's necessary in treatment of cardiogenic shock, and it's necessary in treating patients at home to keep them out of the hospital. Simply, this is a summary of what I'll be talking about. Diuretics, in medical management as in life, the secret is balance. And of course, our goal with diuretics is decongestion. And the counterpoint to that is the development of neurohormonal activation and also renal impairment. So what are we going to do about that? I'm going to focus on these things, and then at the end, we'll talk about managing the patient at home and some new devices and advances that have recently happened in the field. So this is William Withering. I'm sure all of you recognize him. He's the guy that in 1785 described the medicinal value of the foxglove plant, really maybe ushering in the present era of medical therapeutics, if you want to say that. And fast forward a century, and here's Dr. Gachet in this famous painting by Van Gogh. Dr. Gachet was Van Gogh's physician. He looks quite forlorn. He's got the foxglove plant in front of him. I think he's wondering why, after 100 years, why is this the only thing I have that I can treat patients with? And I don't know what it means that Van Gogh died 2 months after painting this painting. So I don't know how good a doctor Dr. Gaucher was. But there he is with the foxglove plant. Now, why did I bring up the foxglove plant and William Withering in the context of diuretics? Well, as you see in this slide, it's an old study, but I like it because it's an animal study that focuses on renal effects. And of course, any inotropic agent can have secondary diuretic effects because of improving cardiovascular function. But here the injection of one of the digitalis glycosides you see there is done directly into one renal artery compared to the other. And you can see the marked increase in urinary sodium excretion that occurs with administration of these agents. You know, sort of interesting that it has a multifaceted benefit. Now go 2 decades forward, and now we're talking about real diuretics. And this was a discovery by Dr. Stringham from Columbia College, my alma mater, I should say. And he was treating a patient with syphilis using mercury, and he discovered that, in fact, it induced a diuresis. And that became our diuretic of choice for about 150 years thereafter. Okay, so what's the point? Well, the point is decongesting. And why is decongesting so important? We see here from these remote monitoring graphs, if you just look at one of them, like the one on the bottom, which is pulmonary artery diastolic pressure, and this is over time in patients with low EF on the top and diastolic preserved EF on the bottom. And in each case, you can see this gradual rise in the pressures over a long period of time prior to spiking and then resulting in the patient's hospitalization. So if you want to keep the patient out of the hospital, you might want to take a look at this and start your decongestion process early. And by the way, you're keeping the patient alive by decongesting them. In this interesting set of data, the dotted line is patients admitted to the hospital who still had significant degree of congestion after 7 days of treatment. And you can see for them, compared to the patients who responded better, their long-term all-cause mortality is much higher. So decongestion is in the middle of our therapy in cardiogenic shock, in chronic heart failure, in acute heart failure. And you have to start with that and know as much as you can about it. Now, so what's the downside? Well, I mentioned that neurohormonal activation can occur, and it depends on how much you give and how fast you give it and to what the patient is like when you do it. This is a study that looked at a small group of patients receiving furosemide versus those in whom furosemide had been withdrawn. And you can see that the patients who continued on furosemide had greater activation of the renin-angiotensin-aldosterone system by plasma-renin activity and also aldosterone. So, and of course, activation of the renal angiotensin system as well as the adrenergic system and other neurohormonal systems is bad for you. We showed that a long time ago, and the first time it was demonstrated that ventricular remodeling could actually be halted or reversed by giving, in this case, a neurohormonal antagonist. We thought we were just giving a vasodilator, but we weren't as smart then. But lo and behold, we found in the patients in control continued to have increase in their ventricular volumes, whereas with the ACE inhibitor, you had an early and sustained reduction in ventricular volumes. I think maybe one of the first times that reverse remodeling was demonstrated. And just to also say that we've shown in subsequent studies, which I don't have time to show you, that this finding of remodeling and reverse remodeling, if you give a therapy to a patient and you induce reverse remodeling, there's a high probability that that correlates with the effect of that agent in terms of reducing long-term mortality. And I would call that a surrogate. We don't believe in surrogates in heart failure, but if there is one, ventricular remodeling is probably the closest thing we have. So many other diuretics have been developed. It took a long time. a lot of development in the 1950s, and they're shown here. I won't go through every one. I'll just mention some of the newer agents, like the nonsteroidal MRAs and the aldosterone synthase inhibitors, which are coming around and being actively investigated. I want to say a few words about a vasopressin receptor antagonist, tolvaptan, which we've studied quite a bit. It's a V2 receptor antagonist that leaves the V1A receptor alone, and that may have consequences. So this is some work we did looking at changes in body weight in patients hospitalized with heart failure with administration of tolvaptan on top of a loop diuretic or the loop diuretic alone, and you can see that the amount of fluid removal, and you may call this not diuresis but aquaresis, but in fact serum sodium excretion goes up. And you can see that it's much greater than in the placebo. Now, what effect does that have? This is a study, we're very proud of the title of this study. It's called The Secret of Heart Failure. I don't know why we called it that. I don't even know what it stands for. But anyway, if you look, this is dyspnea scores or changes in dyspnea scores over 3 days of in-hospital administration of tolvaptan versus placebo. And each pair of columns here represents placebo, tolvaptan, etc. And the benefit really starts coming out in the later graphs. At 3 days, you can see a much greater reduction in dyspnea, either moderately or markedly, in the patients receiving tolvaptan. I mentioned here the slight bump in creatinine that we saw only on day 3, where we were seeing the greatest degree of separation between the two groups. I'll come back to that in a second because it's a very important entree into an important subject. But to finish up the tolvaptan story, we were interested in ventricular remodeling and we were interested in survival. On the left shows the effects of tolvaptan over a year in terms of left ventricular volumes, and the scale is blown up, but there's basically nothing happening. There's no benefit in terms of ventricular remodeling. And as I say, that tends to correlate with whether or not you're going to get a long-term benefit in survival, and lo and behold, this was an acute study started in the hospital, but continued for a median follow-up of 9 months, administering the tolvaptan all along, and no benefit on cardiovascular mortality or heart failure hospitalization, unless the serum sodium was pretty low. And in that group, we did see benefits on long-term outcomes, but it was a small group. Okay, so I mentioned kidney function in that slide with tolvaptan and showed that when we decongested to a certain point, there was a slight increase in serum creatinine. And all of you are quite familiar with that phenomenon. I want to explore why it happens because we emphasize part of it, but we don't recognize a major element of it. And in medical school, I learned the term prerenal azotemia. I had a vague notion of what that meant. I think that term is still used today. I'm teaching medical students, and I see it popping up. And so what does that mean? Well, if it means anything, it's failure on the left side, to drive blood into the kidneys. And that's what I was taught caused prerenal azotemia. Well, in fact, the venous side has unfortunately been relatively ignored. I mean, we sort of know it's a problem, but I think it's actually the principal problem. I think it's actually a more potent factor in terms of driving renal impairment than is forward perfusion. Obviously, the two are interrelated. But venous congestion drives an increase in GFR, and it also drives, importantly, this has been mentioned a number of times, ventricular interdependence, which in turn affects the left ventricle and the ability to drive cardiac output and blood pressure. So think about the venous side. Now, I really like this study. It was done by an early career investigator named Wendy McCallum, who's part of our nephrology group, and we've collaborated a lot with them. These are data from the Everest trial with tolvaptan. But if you look at the left-hand side, pooling all the patients together, patients with at least a 30% drop in eGFR had a significant greater mortality with a hazard ratio of about 1.19. So that's concerning, and people have been recognizing this for about a decade and a half. and the question and have correlated the elevation in creatinine with a bad long-term survival. And we sort of lived with that and said, if the creatinine goes up, we have to stop decongesting. Well, the patients are looking like gigantic garbanzo beans lying there, and are begging for diuresis or for decongestion. You can't just leave them alone. So in fact, when Wendy went back and divided the group into quartiles of decongestion based on either a decline in BNP or an increase in hematocrit and hemoglobin as indicative of hemoconcentration, the ones who had the greatest degree of decongestion had no worsening of their outcomes based on a 30% reduction in GFR. So this led people to start thinking, and the coining of the phrase permissive hypercreatinemia. It's a mouthful, but it's becoming increasingly recognized. And the point is that decongestion should be prioritized over at least modest increases in serum creatinine. This is from a paper that's just been published by the Heart Failure Collaboratory looking at renal measurements. And that's one of the major conclusions of that paper. Don't worry about the creatinine too much if you're succeeding in decongesting, particularly if you're observing hemoconcentration. Okay, so what else is coming along to help us diurese and keep the patients safer and maybe have a more effective benefit? Well, the device on the top there, I know it looks like a vacuum cleaner, but it's not. It's called the Reprieve system, and what it does is it tracks urine output in the course of diuresis, and it readjusts the diuretic infusion rate based on a decline in the urine output. But it does one more thing. It then selectively infuses saline back. And you can see that at the bottom, that it's parallel to the urine output. And there are different ideas about why this helps. My own thinking, one of the things I think is that it may be trying to match the removal of fluid to the plasma refill rate from the periphery. And it's long been known that if you can keep the rate of diuresis comparable to the plasma refill rate, you can maintain vascular volume while you're removing fluid from the extravascular space. And that might be what's going on here, but there are a lot of other theories about this. So there it is. Whether it's going to be practical or not remains to be seen. But here's early data from a pilot study presented by Jim Udelson at THT this year, and it shows the Reprieve system versus control, and we see greater natriuresis over 24 hours and lesser increase in creatinine. So what more could you hope for? So hopefully we'll see this continue to show. In the remaining minutes, I'm going to skip to another topic, which is equally, if not more important, and it relates to the fact that the prevalence of heart failure is projected to progressively increase up through, at least here, the year 2030, at which point the estimated cost for caring for heart failure in this country is going to be $70 billion, and that seems like a lot of money to me. Okay, so what are we going to do about it? Well, since the late 1990s, early 2000s, people have been developing heart failure disease management plans, sort of low-tech, without fancy monitoring devices. And these are two of the studies that we did. The first one was done with telephone monitoring alone, and it showed reduction over 90 days in heart failure admissions and in cardiac admissions. And on the right, we add non-invasive telemetry to the telephone, and we see even greater benefit. Now, I want to make the point that this is the start and the end of the value of monitoring. The monitoring doesn't do anything, really. You have to design a program and a group of people who are prepared to respond to it in a systematic way. That's really the key to making this successful. Nevertheless, as you know, there have been a whole array of high-tech monitoring devices coming along. And the last one I'll just mention is the implantable hemodynamic monitors, which began with the CardioMEMS device. These are two studies. On the left is with the CardioMEMS device. It's called Guide HF. On the right, it's with the Cordella device, more recently with the called Proactive HF. And what you can see from these graphs, that in both cases, the use of these devices in combination with appropriate treatment resulted in a decline in the combined endpoint of heart failure hospitalization and all-cause mortality. So pulling these things together, you can do a great deal to keep the patient out of the hospital. But what else can we do? How can we treat the patient more effectively in the hospital? And what comes to mind is, can we give parenteral diuretics in the home? And we can in the form of subcutaneous furosemide, which is very irritating to the skin. So what's been developed is this compound called Furosix, which is a pH-adjusted formulation of furosemide, given about 80 milligrams over 5 hours is the routine. That's going to be modified over time. But as you see here, again, is the effect on dyspnea scores after starting at the beginning and ending at 30 days. And in each case, in each time point, you see improved dyspnea scores. There also was improvement in 6-minute walk test. There was significantly greater weight loss, and there was a strong trend toward improvement in KCCQ. 51 patient trial, so don't take it to the bank, but there are studies that are going on now, or beginning to go on now, looking at longer-term effects and looking at much larger populations where we'll learn a lot more about the value of this treatment. So I'm going to end where I began. Diuretics in medical management as in life. The secret is balance, and I like this picture of the two dogs having a tug-of-war. It's sort of cool. So you have decongestion on the one hand and neurohormonal activation and renal impairment on the other. But we've learned a lot, and I'll let you read all of the things that I've tried to cover in this talk. But one of the most important things is if you see a modest rise in creatinine in the setting of decongestion, don't stop and the patient still needs to be decongested, don't stop diuresis. And finally, here are these two guys, and what would they be saying today? Well, Withering would be saying, "Ah, gâché, I've driven this field so far, haven't I?" Very humble guy. And here's Dr. Gaucher, a little bit more laid back, a little bit more sullen, a little bit more humble, and he says, "Oh, Withering, it seems to me there's still a long way to go, and that's never been truer than today." Thanks very much.
Thank you very much for a fantastic talk. This is just as a
Oh,
token
wow.
of appreciation.
Thank you. I
Thank you
needed
very
another
much
one.
for being our keynote speaker this year. Awesome.
Appreciate it.
Thank you very much. Thank you. All right. Thank you.
All right. A picture? Okay. Thanks a million.